And we are joined this evening by our two speakers, one of which is also one of our team members here at CCHMC. We're joined by Dr. Susan Wiley and Dr. Jackie Harris. Dr. Wiley is a developmental pediatrician here at Cincinnati Children's Hospital Medical Center in the Division of Developmental and Behavioral Pediatrics, and she's a professor of pediatrics at the University of Cincinnati. Dr. Wiley trained under Dr. Rubinstein, and she's provided clinical care to children, adolescents, and young adults with Rubinstein-Taybi syndrome. She's also the director of the Thomas Center for Down Syndrome and the co-director of the Charge Syndrome Center here at CCHMC, and she's partnered with members of the University of Cincinnati Center for Excellence in Developmental Disabilities, where Kelly and Ilka and I are, in the development of educational information for families and providers, as well as has supported family activities through the RTS OKI, Ohio, Kentucky, Indiana network. Dr. Harris is a child neurologist and neurodevelopmental pediatrician and an assistant professor at Department of Pediatric Neurology and Genetics at the Johns Hopkins University School of Medicine and Kennedy Krieger Institute. She's the director of the Epigenetics Clinic at Kennedy Krieger Institute, and her research focuses on epigenetic causes of neurodevelopmental disorders, particularly intellectual disability, and how specific epigenetic changes lead to specific neuroanatomic, neurophysiologic, and cognitive phenotypes. I did it. She's currently running the only active clinical trial in Kabuki syndrome and is starting other trials in other Mendelian disorders in the very near future. Dr. Harris's research funding includes the National Institute of Health K23 Career Development Award and an award from the Rubinstein-Taybi Syndrome Children's Foundation for her ongoing work in Rubinstein-Taybi syndrome and more. So we have two pretty incredible women here tonight. They're going to share a wealth of information with us. I don't want to delay it too long. So welcome to Development During the Early Childhood and School-Aged Years. And Susan, are you starting?
I don't know. Let's just go for, yeah, keep going there. We got just that. You said so many things about us.
Oh, I'm so sorry. How about this?
No, this is good. Yeah, we'll just start here. I also just want to set a little bit of context. We hope to get through most of our slides, and we know that's a lot of interest in Q&A. So we've tried to break it into sections where we'll take some Q&A midpoints. So kind of that early childhood and then mid-childhood, and then definitely want to make sure we hear a lot about Dr. Harris's research and make sure people have the ability to ask questions about her work. So that just to frame it up of how we're organizing ourselves, and then that's my kickoff.
Great. Yeah. So I'm starting, and yes, and feel free to put questions in the chat as we're talking that we could get to, and then like Dr. Wiley said, we're going to break it up and allow people to unmute and ask questions live at that point too. So plenty of time for that. So we want to start with, you get a diagnosis of Rubinstein-Taybi syndrome in your child. So now what do you do? And these diagnoses are often coming earlier and earlier because of the advent of more genetic testing and that happening earlier on in the process. And so one question that we all get a lot is, okay, I've got this genetic test report. It says that my child has Rubinstein-Taybi syndrome, and I understand that. And then the rest of this genetic test report looks like a bunch of letters and numbers. And does that have any meaning to how my child is going to develop? And so what we know currently is that within any given type of Rubinstein-Taybi syndrome, which, as you all may know, there are two types, Rubinstein-Taybi syndrome type 1 and type 2. So within type 1 and within type 2, there is a minimal correlation between what we call genotype, which is the actual genetic change, or those letters and numbers you see on the genetic report, and phenotype, which is the symptoms or severity of Rubinstein-Taybi syndrome that a child displays. However, we're always learning more. And despite that there isn't yet a known strong correlation between symptoms and the specifics of the genetic change, having a genetic diagnosis is important. And it does help with lots of things. It opens up doors for participation in research and potential clinical trials in the future. And it also allows you to get better counseling about the chances that this could recur in a future pregnancy or anything else when you have the actual genetic diagnosis or the underlying cause of Rubinstein-Taybi syndrome. When we look more broadly at type 1, which is caused by a gene called CREB-BP, versus type 2, that's caused by a gene called EP300, what we know is that EP300 seems to be milder as far as they have a bit fewer medical issues and seem to be less cognitively impaired. But individuals with type 2 do tend to have a lot of behavioral concerns like anxiety and impulsivity and ADHD symptoms. Next slide.
Yeah, we wanted to kind of give a little bit of background to knowing that part of the reason that kids get tested, as well as just kind of the now what piece, is there's so many medical things that kind of may be in front of families and children. And so the couple of reasons we put this slide, one is to make sure you all knew the resource to access that, but also, oh, thank you. Also to just give you kind of some of those key areas that we think about, including things like cardiology, you know, making sure we've had a good evaluation of the heart, you know, hearing screening and monitoring, hearing and vision are really important. You can kind of go to the next slide. And again, so what our medical guidelines have is a little bit of a like, when do you kind of do different things at what different ages? So it feels like there's a lot when you get diagnosed, or if that's early on. And then we try to kind of map out those monitorings over time. I think we can go one more slide, and that's just a little bit more of those conditions. So I think some of the things that often come up as questions, because, you know, I think most families in, you know, if you're in the NICU or if you're in the hospital, or even if there are more common problems that are known, you know, feeding issues, that's stuff that many providers will know about. But there are some conditions that are a little less recognized if you kind of aren't in the know. So we do also think about, you know, kidney ultrasounds, a baseline kidney ultrasound. Boys may have issues with their testicles descending, and we want to be on top of those sorts of things. Vision is also really important because we want to make sure that children have great opportunities to learn and see, and there can be eye conditions that are associated with RTS. I know the tethered cord question comes up a lot, and so if when you're an infant, if you have a little dimple or something at the base of the spine, we might do an ultrasound just to look at that cord, and that gives us a little bit of information, but it isn't like, you know, fully 100%, right? So if the cord looks good, we have a less worry factor down the road. But even if it's normal, or if there's a little bit of a low-lying cord, we will want to keep our eye on the fact that, you know, how are things going with motor skills? How are things going with constipation? And, you know, have you tipped over to us being worried about that tethered cord? And then feeding and nutrition are another big, you know, issue early on. And, you know, how are we getting kids to grow? How are they doing with feeding? And so again, that just really racks up a lot of those specialists. Let's head to the next slide. So I think one of the things that we tried to think about, and we, you know, how do you get your medical team working together. You have a lot of specialists. I'm sure there's a lot of great knowledge in this in this Zoom call, and just really kind of thinking about strategies that one, keep track of how things are going, and that how we get kids working, or how we get those team members working together. So if families have things they want to put in the chat, that we'd certainly be happy to hear, one, what your success stories are, or how did you kind of manage that? I think sometimes it is a little bit easier if your specialists are all in one setting, that they may be able to see their records readily and maybe work together well. But I know areas may have different systems or different hospitals, and so that makes it a lot harder to get that coordination. Sometimes families also find like a complex care clinic. Again, those aren't everywhere, but then you kind of have a hub primary care doctor who may have additional supports like care coordination, social work, who can also kind of help families navigate healthcare costs. What are the different waivers or things like that that can help us access what we need to access. I don't know, Jackie, if you had other.
Yeah, I agree with all of that. And yeah, if you can, it's different at different institutions. Sometimes it's a geneticist, sometimes it's a neurologist, sometimes it's a developmental and behavioral pediatrician. It can totally depend, but a lot of times if you could find at your kind of center or hub a quarterback of the care, so to speak, and someone who can help you manage and help you say, yeah, you saw this specialist, everything looked normal, you really don't need to keep going back to cardiology, say, when you've had a completely normal echocardiogram. And something that we talk about is, we as doctors, we never want to feel like we're pushing patients away, right? And so we often say, oh, come back in this amount of time, or come back in this amount of time, a year or 2 years, whatever, even when, there might not be really any reason that you need to say, keep seeing that specialist from an RTS perspective. And so that's why sometimes having someone who can oversee the whole thing and say, gosh, I really think that, nephrology said come back in 2 years just because that's what they say, but clearly your kidneys are fine and we wouldn't expect anything else to go wrong, just based on the RTS alone. So I think that's one thing off your plate.
Yeah, and I think the other piece, you just made me think of the fact that sometimes if children need sedated procedures, can we do that one sedation and coordinate? But again, your specialists have to be willing to work together, find that cooperative sedation time or operating room time as a mechanism to try to have fewer anesthetic events. I did see somebody in the chat has found complex care is actually a great game changer for them. Another question is whether everyone with RTS should get imaging to check for tethered cord. Particularly, and it is true, sometimes kids are diagnosed much later. People didn't recognize things early on. Jackie, what's your usual approach for that?
I don't universally check because I feel confident in, being able to do an exam and pick up on symptoms that would pick it up. And even, sometimes when it's diagnosed later in life, it's very unfortunate, but it may not have, been really affecting anything earlier on where you would notice symptoms. And so, to me, early on, without any symptoms or physical exam findings that suggest a tethered cord, the risk of a sedated MRI and another sedation in an RTS child who often has many is not worth the risk benefit in a child with an otherwise normal exam and no symptoms of a tethered cord. So I think it's important to bring it to your provider's attention, but as long as you feel confident that you have a provider who could do a good exam and take a good history, I don't think that it needs to be a universal thing that you have to sedate your kiddos an extra time to get that MRI.
No, I agree with that. And then I also realize sometimes I've had kids come from other settings where people haven't been thoughtful about that exam and thinking it through. So I see why families would just let me image and then I'll, then I can have that information. But truthfully, even with imaging, if it looks tethered, it doesn't necessarily mean that it's symptomatic. So we might say we're going to keep an eye on that, and maybe look at other factors before doing something surgically. So what you might see in a tethered cord, particularly you see more issues during periods of growth where there might be stretching on the cord or on the spinal cord. So you will see maybe worsening constipation, urinary retention. You might see a change in how a child's walking. So those are kind of some of those factors. I will say when I have a child who's got, I mean, a lot of kids with RTS have constipation, and we will have a GI person next month, I believe. So we'll let that to them. But when it's really over the top, that's the other piece I go, well, should we be looking at that? Because you've done all the right things of trying to keep the bowel movement soft, trying to keep things moving through, and we're still just really in a place where we can't get in front of it.
And changes in bowel habits too are a big one
Yeah.
for me. Like if the kid went through a growth spurt and now they're having constipation where they really weren't before, what's going on there. The other thing, as a neurologist, that I think of when I'm thinking about a tethered cord is if on exam, if there are differences in the neurologic exam between the upper portion of the body and the lower portion of the body, because pretty much all kiddos with RTS have hypotonia or low muscle tone, but it's pretty consistent throughout their body. And if there are any differences, it has more to do with it's more centrally located than in the extremities. But if I'm seeing a big difference where the bottom half of the body is really different than the top half of the body, then that's a warning sign for me that I should probably look deeper.
Yeah, I think I agree. And the other, we'll move on pretty quickly here soon. But the other thing I see our neurosurgeons do a lot is get what's called urodynamics, because what that does is look at how the bladder is emptying, and it really is a good link to understanding how the bladder is receiving that innervation and whether or not that gives more information to suggest, yeah, this is actually a problem we need to do something about. So I think, getting to I mean, I'm a little bit of a, because I work in a pediatric institution, I do think pediatric neurosurgeons really do know this condition where sometimes, it just depends again on your region, but those pediatric neurosurgeons will kind of guide that course.
And I would strongly say, based on what you were saying earlier and, both of our experiences, a tethered cord is something that you should have if you're not confident, especially if you're not at a major pediatric academic medical center, it's something that you should be willing to get a second opinion about, because, we've both seen, as Dr. Wiley said, cases that should have been intervened on that weren't, but I have, and I'm sure Dr. Wiley has too, seen the reverse too, where somebody pulled the trigger on doing a neurosurgical intervention on a child who probably our neurosurgeons wouldn't have done that, and then there was a complication or something went wrong. And so it's definitely something that you should have a pediatric neurosurgeon that you feel confident in looking at that imaging. And I realize we're very privileged being in Baltimore and in Cincinnati where we have that at our disposal, and not everybody does. But that would be an area where I would say step out of your comfort zone if you're able, and see somebody who's seen other, if not kids with RTS, then kids with genetic disorders that predispose to tethered cords.
Yeah, because I think I know, and we need to move on, but the other thing you just made me think of is sometimes I have gotten questions about like, well, this isn't the medical condition that my child has. Should I come to you because you guys know RTS? But if the care around that condition is the right, the RTS doesn't necessarily say I treat the heart differently. So again, if you have comfort in your team, that's totally good. Let's move it forward, because I think we wanted to Yeah. Do a little bit on therapy, and oh yeah, totally happy to talk. Maybe we need to do a tethered cord / neurosurge topic at some point. I know that's comes up a lot with people worried about it. But I think the other piece that I realize is that, you get all of these great opinions, and all of a sudden I have to do 20 hours of therapy or doctor's appointments or this and that and the other. And I think it's sometimes challenging. And I love, Dr. Harris's statement about, hey, if you don't really need to go to somebody again, ask, what's the purpose of me coming back? But even that therapy, how do you decide your priorities around how many visits? What are we focusing on? And I also think developmentally a little bit with that in terms of, if we're working mostly on feeding and motor, let's just put our energy there for now. And not to say I forget about communication, but we can do that in a lot of different ways. If you're in early intervention, there might be, EI specialists or developmental interventionists who can kind of make sure we're not missing the bigger picture. But I have had families who've tried to do things like, hey, we're going to have a day a week where we really try hard not to have appointments. It's not perfect, but at least that way there's some family fun time, and it's not just all therapy and medical, because we want kids to enjoy life, have fun. You have fun with your child too. And just also be that hub of what are my priorities, and making sure that we as providers, whether we're medical, therapeutic, educational, are listening to you and keeping on top of what your priorities are and where you want to put your energy.
And anybody who's ever seen me in clinic knows that my favorite thing to say is that there's lots of evidence that says that for neurodevelopmental disorders that therapy is good. There is no evidence in existence that says that more and more and more and more therapy is better. And so there is lots of therapeutic value to all the other things that, families do and children do besides going to therapy. And so that is important too. Family sanity is good. Your other children are important. And so all of those things. And so, if you are in a therapy and things are, and just by nature of chronic therapy, because the kind of therapy that you do for RTS and all neurodevelopmental disorders is not rehabilitative therapy where you're working towards a goal of getting back to a point you were at before. It's therapy to make progress. And so by nature, all of these things have a tendency to stagnate, right? Because it's the same kid and the same therapist, and you're working on the same things. And so I just, all families and caregivers should be empowered to say, let's step back. Let's take a therapy break. Maybe I need to focus right now a little bit more on PT. And so let's do that twice a week. And I'm going to give OT, I'm going to go to OT once every other week or whatever. Maybe PT's good right now. We're just working on balance and coordination. We're going to go to once a month, or we're going to take a break from it and come back to it when we need, when we have a goal to work towards again. So feel free to question your therapist, say, what are we working towards? What is the goal? What progress are we seeing? And, trust yourself. If you feel like you're not seeing forward progress, maybe it's time for a little break or a little change.
Yeah, we can forward a little bit. Some of these are kind of connected with what we're a stream of consciousness presenters, but it works because this kind of does link into, we do want kids living in community, and they're part of your family, and we should be asking them. And as I guess the idea is focus on the donut, not the hole, right? So what you can do, you're part of our family. You have chores too, at your level. But we also want to think about like those extended family members, because those can, our family members can be huge helps and support, but also may not have had a lot of experience with kids with disabilities and medical conditions, and then thinking about siblings. So a lot of times, we really don't, therapy or medical appointments seem to overwhelm the weekday. And how do we find that balance with siblings? I know we do some SIB shops through Children's, and those are a national program. So that's certainly something that can be really helpful. And I think a lot of times when I know I hear families worry that, like, well, is my child's sister or brother going to feel like they're a therapist? I'd have to say that, yeah, you don't want them being the therapist all the time, but they definitely help push kids forward. And what I feel like I find, and, I remember this at the conference, is just looking out to those siblings in the audience and recognizing what amazing people they're growing up to be. And they are our future of inclusion. So it's, yeah, it can be bumpy at times, but there's a lot of positivity there as well. And then, I think too, just like sorting through that information. And this is one, this is even a forum too, is like, well, did that apply to me or did it not apply to me? Because a lot of this stuff on the internet can be kind of scary. And it's also really, I think, particularly when kids are young, or even with a new diagnosis and you're at an older age, well, what does that mean now? And how do I get to that thriving and not just like surviving? Yeah, I'm loving the chats too, because I'm seeing some stuff that families are seeing. But go ahead, Jackie. Yeah.
Oh, and I was just gonna say regarding, all of the groups that you all participate in, right? All of the RTS Facebook groups and other, other social media and things like that. Again, remember that number one, we already know that there are different types of RTS and there are differences there, right? Number two, every child who has RTS also has other things, going on, just like any child in the world. So it is not all a monolith. So, you use each other to support and to share similar experiences and find common ground. But it doesn't mean that any family who shares an experience that sounds terrifying, that is absolutely going to happen to your child. And then the last thing that I wanted to say is, support groups, it's not like there's some sort of gateway where it requires a, genetic test to be able to get into the support group, right? So again, this is a trust yourself kind of thing where if you're hearing something, that sounds way, way different than anything that you have experienced, feel free to, check yourself and say, gosh, maybe something is going on with that child is different than my child. And it's okay for me not to have to worry about it. And that's, again, if you have providers who you trust and talk to, feel free to talk to them. Hey, I saw this on the group. It really has me worried. Can you give me any information about this?
Yeah, great points. I think we're kind of at a reasonable, like, 'cause the next section we have a little bit on like school. So I think if we wanted to take, maybe 10-ish minutes to ask some questions, and then we'll do a little bit on like kind of the school navigation, and that will be the next session. But if there's questions about medical stuff or just like balancing all of that, the medical circus, happy to take questions, or I'm also just seeing a lot of good ideas in the chat and a lot of head nodding, I guess.
I see, one comment in the chat, and I just wanted to, to say another thing is to remind you all that, you get a lot of diagnoses and your problem list increases as related to Rubinstein-Taybi syndrome. And so the important thing here is, you could sit around and say, why am I so unlucky, right? Like, how did I get a kid who has all of these different things? And it's important to note that a lot of diagnoses, for instance, the neurodevelopmental diagnoses that Dr. Wiley and I deal with most commonly, they are descriptions of symptoms or behaviors or manifestations, right? They are not underlying etiology. The underlying etiology here is RTS. So it's not that your kid got super unlucky and got 35 things, right? Your child got Rubinstein-Taybi syndrome, and that manifests in different ways. It can manifest as, intellectual disability, as autism, as congenital heart disease, as all these other things, but they're not different things. It's not different buckets. It's just manifestations of, say, brain dysfunction due to Rubinstein-Taybi syndrome.
Yeah, I'm seeing the RTS is the umbrella, and I'm also seeing, I'm definitely seeing some questions about behaviors. And I think we can cover a little bit of that, but I also believe we are going to have a session from a psychiatrist and a behavioral counselor in the future, like a psychologist. However, I think, yeah, we can definitely see issues of anxiety, OCD. I guess I hear a lot from families, like repetitive questions. I know I've told them 20 times what's for dinner, but we're still on that concern, or that's what I can't get my head off of, or impulsivity in school, and how do we navigate, what's the right supports behaviorally and some strategies. I think sometimes too, families also kind of go, okay, well, where are the counselors who can help a child like mine? And particularly if, there's a lot of strategies that can work as long as they're kind of tailored to your child's capabilities and processing level. So whether we have to do more, I always think about for younger kids or kids who are having a harder time processing or self-regulating, how do we teach those self-regulation skills, but also how do we help life be predictable? How can visuals help support kids' readiness for, or that anticipation of events, or social stories can be helpful if we're trying to teach a new skill. I think too, like just really trying to figure out, well, what are there things that we can make environmentally work a little bit differently to reduce anxiety? And then what sort of breaks or strategies can we implement if we're needing a break or we're overloaded? I love the how does my engine run sensory work from OTs, just to kind of give some strategies and some concepts around that. I do see a hand up too. I feel like I rambled a little bit there. Yeah.
It's me, Susan. I'm wondering if anyone else is dealing with the MTHFR genetic variant being an issue. We're having a really hard time just finding medication solutions because of the way my son metabolizes. Seems like we're the 1%, nothing works. We get all the symptoms, not a lot of the grace intended. And it's been really interesting to see, even with our complex care physician, how very simple medications, ones that are the most targeted, the least invasive, we still, even at the lowest dose, have the biggest reactions. And then we have to pull ourselves off. And we're just, going through puberty right now with him turning a couple days. And we're trying to find all these solutions for the OCD, the anxiety. And it really seems like we're almost like, I don't want to say hopeless, but there's very little out there that doesn't cause some kind of a major storm on us. So that's something that I didn't consider, was like medication efficacy, working with a child who maybe has complexities with even just metabolizing or processing or clearing. And I'm not sure if anyone else is looking for the MTHFR genetic variant, but that was something that has been a bit of an aha moment for us of like, oh, that might be part of this conversation. So I just wanted to bring that up if anyone's downstream from us and have younger children.
No, I appreciate the call out, because medication management isn't necessarily straightforward or easy and in anyone, but also there's so many layers, right? And including how does my body to respond, but also how does my brain respond in that use of that medication and the side effect profile. And then if, depending on your child's capability to let us know, how they're experiencing those side effects, what's their communication level to, have we actually made things worse because of the side effects? And all of a sudden, I do worry sometimes where if families are seeing folks who just keep adding more and more, or it's not to say that sometimes kids don't need 5 medications for 5 different targets, but that always makes me a little worried, what's really doing what? And I get the targets and maybe, but now we're this far down the pike, and what do we do now? I don't know, Jackie, if you have other.
Yeah, no, I agree. It's really hard. It's really complicated. And one thing that I always point out is, unfortunately, none of the medicines that we have treat RTS, or the molecular mechanisms underlying it, right? We can only treat target symptoms. So the things that I will say is, before you start anything, make sure you're understanding with your provider exactly what you're targeting, because in RTS, overlapping kind of neurodevelopmental diagnoses are the rule, not the exception, right? So you have, impulsivity, and you have anxiety, and you have, inattention and things like that. And so what is this medicine actually trying to treat, and making sure that that. And then exactly like Dr. Wiley said, I multiple therapies are very often necessary, right? Again, because these therapies are not precise to RTS, but my mantra is I really never do two things at the same time. Like any change that I make, I only change one thing at a time, because otherwise it's very difficult to know if you get a side effect or even a positive effect, right? What is doing what.
Yeah, and I think one other thing I often talk about is the anxiety attention seesaw. So the medications that help anxiety make your impulsivity and attention worse, and then the medicines that help your attention and focus make your anxiety worse. So how do we find that right place on the seesaw between those two? And that's really, again, as people were noting in the comments, that it is, a common challenge that, and sometimes too, what's I find like kind of sad in retrospect, because I use my my medication toolkit, is that sometimes all of a sudden a change in a school team, everything's different. And and it really was, what were those supports and strategies that were needed? And then the other piece that we probably haven't like hampered on enough is just communication. So how do we get our kids figuring out those communication capabilities? If a lot of children may have, can have the difficulties with speech production, and so not being able to communicate, of course, behaviors is going to be your approach. So whether it's OGCOM, signing, visual supports, we got it. That's I think the other piece is, agreed, there's a lot of medical stuff early, but how do we make sure that we're building a communication system for kids? Because that will help in the long run too. All right. I think maybe we could move, because it's kind of is kind of pushing into, the pain one. Thank you for that. Sorry, I'm trying to catch up on some of I do think it can be tricky, because if children are having a harder time, like I hear a lot, like they fell, they didn't seem to cry, and then, like with just different pain tolerance, and and yet then there's also constipation, which can give a lot of crampy pain. And how do we find that right mixture? So I see the pain team as a resource. I think that's a great thought. And just kind of we have to, I usually think head to toe, if something's different, is there some medical precursor? But also that may be the case, but then does it turn into a behavior because now something, we responded in ways that now have reinforced that behavior? So I am seeing, a lot of that is tricky. Just how do you find the balance across the medical pieces? So the side effects of seizure meds and that sort of thing.
Yeah.
I see a question. I don't think renal ultrasounds are indicated yearly, or unless you had
There's
a
a
condition that
problem
you're
that-
monitoring,
yeah.
right? So if there was, I don't know, a small size kidney or something that they're concerned about its growth, or frequent UTIs, we may do some workup if there's something happening there. But typically that's based on a lot of the early testing is like, are we looking for things? And then what is the interval of follow-up on based on what we found, not necessarily keep doing them over and over.
Yeah, for renal ultrasounds for RTS, again, unless something was found that's being followed, it's usually looking for something congenital. So once you've had it once, if everything looks fine, there wouldn't be anything that we'd expect to newly pop up.
And Jackie, I honestly don't know this answer. Do you know the percentage of kids who need to use more augmentative communication systems and have limited speech? Do you feel like you know that percentage?
I don't think I know the percentage. I could sort of roughly say how, if I'm thinking about my population that I've seen, how many kids with RTS are kind of what we call functionally nonverbal, right? That doesn't mean that they can't say any words. That means that speech is not their primary method of communication. I would say 30 to 40% would be somewhere around my guess for that.
Yeah, that sounds about right to me. So, and I guess that, so I was looking, there's like if a cardiologist cleared you, I think you should be good to go. The only change on that I would say is if kids when they are older develop sleep apnea, there might be some monitoring of the heart related to sleep apnea. But in general, if your structural heart was fine, only if something comes up, like, if just like any child, if you started having a fast heart rate or something's different, then I think we go back. So. All right. Well, I should have let this one to Celia because Celia does so much of the educational work, but I do feel like school becomes alphabet soup, Part C and EI and IFSP and IEP. So we'll pop forward a little bit. I think, thinking about that, going off to school and putting your child on the bus and who are these people going to care for, who are these folks? Because I think even EI tends to, you're so involved in the early intervention system. They're coming to you. You're the central hub of the team. And that should be the case at school, but often schools are kind of like, we got this, we know what we're doing. And you feel a lot more disconnected, I think, or it's easy to feel more disconnected, and just really, feeling comfortable with the team that you have. Yeah, I don't know.
Yeah, I agree. I see a question in the chat about does more intensive speech therapy help earlier rather than later? And I think the answer is it depends. So as far as I think the key question there is the intensive part, right? And so for me, I feel like intensive therapy is most useful when any therapy really, but especially intensive therapy is useful when you have a specific goal that you're working towards, and that goal is within an achievable range. So some families, like just a really easy example, some families do a little burst of more intensive PT when that kid is really, really close to walking, right? But that hypotonia that comes with RTS is just, and a little bit of the anxiety too, is just really keeping that kid from taking those steps, because there's so much that comes once you've reached that threshold skill. And that's where really intensive is useful. I don't think that, getting, there's not evidence, let's say. It doesn't mean there's not evidence to the contrary either. There's just no evidence in either direction to say that if you get speech therapy 4 times a week from 0 to 5, that it actually is going to change the trajectory of your child's eventual speech down the road. The speed, perhaps, but the eventual end trajectory, I'm not sure that it does.
Yeah, no, and I mean, I do recognize, like, we do a lot more pushing. It seems like we do more pushing at younger ages. And then when kids are older, like, are we backing off, and why are we backing off? And it might be because you have, their skills have been developed, or your communication system you've kind of figured that out, whether it's using technology. And so then it's more about, okay, I got to use this in life, and how am I using it at school? How am I using that in the community? I think the other, I guess too, why it is important to think about communication, and there's lots of ways to communicate, but I think you really also want to be working with folks who really understand, like, where are you at? Where's your child at? How do we get you to the next level? So is it more, we've got to figure out our turn taking, and our back and forth and our choice making. Are we ready for that next phase of, higher higher abstract thinking? Are we also, or are we, what are you motivated to communicate about? So there's so many things that go into getting those communicative functions moving. And then also, what is working for your child? That sometimes kids understand a lot more than they can say. So of course we want to try to find the way that is less frustrating and least frustrating. So whether that's signs, whether that's pictures, whether that's technology, while we're working on the speech. So what I think is also important to recognize is when we do implement some systems like this, it actually takes the pressure off, because I was able to communicate with you, and then maybe the speech comes a little bit more readily. So again, there's every kid's their own person. I don't know what your thought is, Dr. Harris, but like, I don't give up on speech. Maybe if you're not talking substantially by 7 or 8, I'm much more worried that you really do need a more we should have had a formal system in, but it may be harder for you to develop a lot more spoken communication that is understandable.
I totally agree with all of that. I couldn't agree more. And I just want to reiterate exactly what Dr. Wiley says, because I get this question a lot. I know she does too. It is important to know that this is very data driven, right? The data is that communication begets communication, right? And so using assistive technology or any other alternative method of communication beyond speech is actually helpful to the production of speech. It is not detrimental. So, if we could stress one thing, please don't ever let anybody take any method away from your child that enables them to communicate, because it is not reducing their ability to use verbal language.
So, and I see a question in the chat from somebody who's going to be moving to the US, and it kind of goes nicely into the next slide, because, schools do provide therapy through the IEP, so with the Individualized Education Program. And I think that meeting, I think they're a little overwhelming personally, in terms of just the teachers and the specialists all telling you what, they think is right. But I also recognize that sometimes families do a combination of school-based intervention and private therapy. And when that happens, my sense is usually it's because there might be differential skills in a clinical setting than there are in school. And school is going to focus on certain things, and maybe a clinical setting might work on other things. So again, it kind of depends on that age. Where are we at? Preschool, school age. Self-help schools. Self-help is a kind of a strategy that we do a lot in preschool, but at older ages, sometimes the schools kind of move on to other tasks. And so, am I trying to tie my shoes? Am I trying to work on toileting? Those might be things that, yes, are supported by school, but are helped more broadly. Feeding is another one that it typically is probably less common for early intervention or school therapists to have a lot of skill set in feeding. So, but you can have that. Here's the approach, here's the diet. Can somebody, kind of follow through with what a clinical therapist might be guiding you on? And then how do we make sure that we communicate across those settings so that people are kind of lined up and not pulling a child in too many directions? I know sometimes families have used a communication notebook that goes across the settings, or, other strategies to link those clinicians and educators with the right, privacy forms that everybody's comfortable, communicating across the settings. I think too, so the other thing, I think families are going to be great supports. Many schools, or at least many schools in our area, also have like a family advocate. They're still paid for by the school. So, they're still going to be, kind of more on a little bit more on the side of the school, but they should be there to help support you and understand that process. And certainly that's something, again, we could add to the series with Celia, given a lot of good information on IEPs and how do you kind of bring your team together, when these other questions is, should I do testing? I have a lot of families who try to figure out like what's the right educational label to get what's going to be helpful for my child. I think even those questions about integration and mainstreaming versus more restrictive environments or a combination of such. And I see that sometimes as an evolution. Sometimes in preschool, there's a lot of integration and blended classrooms, but sometimes as kids get older, school districts may have a harder time supporting children, whether that's an aid or is there push-in services where people are going into the mainstream setting. And I think a lot of times families have to just make that what's my child working on, where are they learning it best, and finding that balance across those skills that you're working on. Let's see if there's any. I don't know if you have other thoughts. School age stuff. Yeah, you probably.
The school is what Dr. Wiley and I end up talking about at a lot of the visits for most of the time. And different kids are different schools are different school districts are different, and they have different programs and different settings and things. So it's impossible for us to say is public school right or non-public placement, because it depends on where you live and what district you live in, and what are the needs of the child. But one thing that I always tell families is, it's a lot easier to negotiate with a school to pull back and get less services or a less what we call restrictive environment, or things like that. And so if an IEP, if you're just starting out and you're going from kind of preschool to kindergarten or whatever, and then IEP is willing to give you lots of things, take those lots of things, and you can always step back if that's what's right for your child, at the next meeting.
Yeah, and I saw something about would every child always need an IEP or not? And again, I think that's really what is your child needing, not needing. So sometimes if kids are doing quite well and they just need a little accommodations, again, I've had some kids who just more having like the attention anxiety piece, and learning is not a challenge. That can really look more like accommodations or strategies. I think too, if sometimes the other thing that we will encourage is if children are having difficult behaviors at school and people are really not sure what to do, one thing you can ask for is a functional behavioral analysis, where you really have a school psychologist come in and try to understand like what's truly happening, what's the behavior, why might it be happening, what might this classroom be doing that it's keeping that going or inadvertently reinforcing things. And again, that would guide hopefully some new strategies and new ideas. And what I commonly find, and Celia will probably nod her head, is how we got to remember that positive reinforcement, because that is often what people forget, because we get into this cycle. Or it's easy to get into that cycle of somebody's not cooperating, or they're flopping and dropping, or they're they're throwing things, and now how do we get back to a positive approach, and how do we reinforce what we're trying to build?
Yeah, I see some comments in the chat, or some questions. Do most kids with RTS end up in special education through their life? And how do I know if my child needs an IEP or not? So here is what I will say. I have not yet. Maybe Celia, Dr. Wiley, you know of differently. I have not met the child with RTS who should not have an IEP, right? That doesn't mean that child needs to be in a self-contained classroom or anything like that. Certainly there are kids with RTS who are totally appropriate, learning in a mainstream classroom with supports, but I don't know anybody who shouldn't have an IEP at all. I think that is wise, given, that we know that academic and behavioral struggles are common, and it doesn't hurt to have one. And have those supports in place in case you need it. And do most kids with RTS end up in special education throughout their life? I mean, the answer is yes, most of them do. It doesn't mean that's exactly the same, looks exactly the same for everyone, but the answer is yes. But special education can mean push-in services into a mainstream classroom. It can mean a self-contained classroom. It can mean different things. But yes, I would say that most to all kids with RTS, have some special education services through their life.
Let's pop one more forward and then I want to make sure, because we do tend to, I tend to just be too chatty. I think the peer network is also something too. And again, maybe what we need to do is for these, like, let's think about that as another session. Like, how do we make sure that kids are included, that our community, that we have accessible communities. But I do want to make sure we had time for Dr. Harris's research. And it is 8 o'clock. So what my best my best intention of 10-minute breaks in between, but let's move on if that's okay. The chat's been really great, and you guys are a great support network. I know your experiences supporting each other is probably way more than what Dr. Harris and I can convey. But so we're going to let Dr. Harris talk a little bit more about her science, and then we'll still end with some open Q&A time.
Yeah, so a question that comes is sometimes, okay, I'm doing all these things, IEPs and therapies, and got my medical specialists and things like that, and is there anything else? And so the answer to that is right now, no, but we hope so very soon. But in order to do that, we need to do some more research. And so, I'll just start with saying that it is now 2024. So now 21 years ago, there were 2 papers published in the literature in prominent journals saying that in mouse models, they could correct the symptoms, the cognitive symptoms of Rubinstein-Taybi syndrome in a mouse model with some drugs that could be available. And so 21 years later, there haven't been clinical trials in RTS to test therapies. And why not? Well, the answer is because it's not enough to just have a potential drug or a therapy. You also need to do studies to understand how are you going to test these therapies? What are you going to measure? What does it look like? We've been talking this whole time about how all kids with RTS are different, and they are. But one question is, what is something that is RTS, right? What is very similar or the same among all kids with RTS? What is it that makes, RTS, and how can we target those things and measure those things and design these clinical trials to test therapies? Next slide, please. And so, some kind of words that we use in this space are outcome measures and biomarkers. So outcome measures are the way we test whether or not something makes someone better, right? Because it's not enough for me to give your child a therapy and say, so are they better? What does better mean? What are we looking for? How are we measuring it? How much better is better? All of those things. And for RTS, as you've heard in this presentation, right? Yes, there's medical things. We talked about that at the beginning, right? But as we move forward, especially as kids with RTS, go past that baby stage, what we hear again and again is that the predominant thing that families want to talk about is neurodevelopment and behavior and those kind of things. And so how do we make sure that those things are the primary focus, or at least one of the primary focuses of clinical trials in RTS, and how do we measure this? Next slide, please. And so one of the things we need to do is, if we're going to test something to make someone quote unquote better, from a cognitive standpoint, we need to have good cognitive measures that are good not just for the general population, but for kids with Rubinstein-Taybi syndrome. And so that's what we set out to do several years ago. And we were looking for what areas of cognition we wanted to target for a clinical trial. We did some measures that we did on the iPad to try and get good cooperation and performance because, you know, we heard feedback from families that kids with RTS really engage well with technology, and hey, they're great on their iPad, right? They can, you know, navigate that thing like you wouldn't believe. And so let's see if we can get something out of it. And so next slide. And so what we found is that they did great with the iPad, and we were able to get participation and get measures from even kids who, you know, a lot of people would call, say, lower functioning, or kids who were more impaired cognitively with RTS. We were still able to get scores. Unfortunately, what we saw is that the iPad measures, while they were able to test the kiddos, they were not very good at discriminating, you know, what we really wanted to find out. They really didn't help us to say what looks good and what, you know, what parts of RTS are most impacted, because as you can see in this graph, they kind of scored the same across the board of all domains, and they scored the same low, which means the measures were not sensitive enough. It doesn't mean the kids did poorly or did anything wrong. It means the measures weren't sensitive enough to detect the differences. And the only big difference that we saw very clearly is that the kiddos with the type 2 had overall cognitive, higher cognitive scores, but they struggled comparatively with executive function, which is like their attention, their shifting, their regulation. Next slide. And another thing that we found that's really important that, you know, I've heard even echoed in the questions and comments in this forum is that the kids' cognitive performance was correlated with their parents' rating of their behaviors. So the worse their mood and behaviors, according to the parent rating, the worse they did cognitively. And this was this was on this specific cognitive test and was independent of what would be their overall kind of full scale IQ score or whatever. So the more behaviors we saw, the worse the performance on these measures. And so it's really important to get good behavioral measures in addition to the cognitive. Next slide. So what do we do next? Well, the iPad worked well, but we need much better, more sensitive measures. And so we redesigned based on this data. We want to look more deeply at type 1 versus type 2, and we want to get better at correlating with behavioral data so we have the best, most precise measurements of our kiddos with RTS and adults with RTS. Next slide. So the other thing we want to look at is biomarkers. And basically a biomarker is something that can go along with like the cognitive testing, something that we can also measure with the cognitive testing to say whether it is getting better. And sometimes that helps us, you know, be more sensitive and picking up when things are really helping, especially in a neurologic or neurodevelopmental disorders. It also improves the chances of clinical trials moving on. And, you know, some of you who follow the news on this may know that there's been a lot of recent, unfortunately, drugs in rare diseases that actually showed really promising results, and the status is unknown because the company has dropped them. So you really want your clinical trial to look really, really good, and biomarkers help. Next slide. So we are looking at a biomarker that has to do with an EEG. And a lot of your kiddos have had EEGs on a clinical basis looking for seizures. This is something very different. This is an EEG that is actually measuring how the brain learns. It doesn't really have to do with seizures. And this is based on what we see in these mouse models in those previous paper, and shown how this learning can be impacted. Next slide. And so, so we basically play some sounds, have the kids listen, and, you know, figure out how their brain's learning from it. Next slide. And so, we are looking to see if the kiddos with RTS have a different response to learning than controls. Controls being kids of the same age, the same sex assigned at birth that do not have RTS. Next slide. And so we're trying to move this forward. So we're actively recruiting for this biomarker and outcome measure. It does involve a visit to Baltimore, but we do have some travel funds available for this. And, it would be a 1-day visit where you'd get some cognitive testing, an EEG, and a blood draw. Next slide. And this is how you would contact us to participate. And I, kind of rushed through that to leave time for any additional questions. The last thing I wanted to say is, I know we gave this this presentation at the conference in June. And I know that a bunch of you who may be on this call have emailed us. And if you have, I wanted to say that we absolutely have not forgotten about you. We have you in the queue, and we plan on contacting you to come if you are still interested. And we apologize for the delay. And what happened is we switched to a newer, much better, much cooler EEG machine, but that took a little while to buy and, calibrate and get set up, but it is, ready to go. And so we are ramping up the study. And so we apologize for the delay, but we wanted to make sure that we have the best equipment to get the best data that we possibly can in RTS. And for anybody who participated in the original study that helped us do it, that data is, we are submitting that for publication hopefully 2 weeks from now is the goal that I've set with my grad student. And so that will be out there. And yes, you could participate again, because this is a totally new study with, similar measures, but looking to, ramp up and scale and really validate these things.
Yeah, there was also a question to do if there's a link to the paper about the mouse model, so we can.
Yes.
Awesome. But yeah,
I can, it might be even easier. I could definitely link it. I don't know if it is open access or
yeah.
not, but I could send I could definitely get the PDFs and send them to Celia and Kelly to get out to everyone. That's no problem at all.
You kicked it out there. Thank you. We do have 20 minutes yet, which was good.
Has anyone done MRIs to see brain changes? So on a research basis, not that I can think of, there have been some studies published on a research basis, like looking at just, MRI changes that are seen in Rubinstein-Taybi in general. And the answer is you could see lots and lots of different things. Most of the changes that we see on MRI are what we call kind of non-specific findings, which means they're definitely different than what a quote unquote normal MRI would be, but they're not anything that we think would make any functional difference other than just having RTS itself. But, it's kind of another symptom of RTS, is seeing these little changes on MRI, but, they usually don't have impact, which is why, just like we were talking about for tethered cord, even more so for brain MRIs, unless you are doing a workup for seizures, which is a totally different, conversation, because there's lots that brain MRIs can tell you there. But, beyond that, we don't recommend just routine screening or baseline brain MRIs in Rubinstein-Taybi syndrome, because I don't know, 95% of the time, it doesn't tell us anything that we don't already know.
So there's a question about the drugs. I don't
Yeah,
know
so
if you have-
histone deacetylase
Yeah.
inhibitors are the drugs that have been tried in the mouse models, and I will pull the papers and send them. But yes, that's what's been looked at.
So Nicole has her hand up, but there's also a question about epilepsy, and you are the neurologist. So I'm gonna
So the answer is like anytime, right? So it's not unfortunately there's not a time when I could say, oh, you have RTS and you haven't had a seizure, you're totally out of the woods. Certainly there are times that it's more common for it to start. So we sort of see the same, as far as we know, we sort of see the same kind of what we call dual peaks in epilepsy and RTS as we do in other seizure disorder, other types of seizure disorders. So you see one peak kind of early on in childhood, and then another peak sort of towards adolescence, and that's most common. But it doesn't mean, like, I've seen adults who never had seizures as a child and started having seizures, and I've seen kids who had seizures very young and then never had them again, and it wasn't an issue. And so we don't have enough info to say, hey, you're out of the woods. And what is there to look out for? So this is what I always say about seizures in RTS, right? I do not want you to put a monitor in your child's room and stay up all night, every night, watching the monitor to see if they twitch funny and, get freaked out about it, right? It's more of a kind of, if like the airport thing, right? If you see something, say something, right? So if you see something that looks very unusual, say something, and take a video of it, and send it, and ask about it and whatever. If you see your child staring off, the vast majority of staring spells in RTS are not seizures, although some are. What I will say is that there is no seizure that you can kind of get them out of by grabbing their arm or whatever, right? So even, and kids with RTS can be quite hyper focused on things at times, or inattentive at times. So if you're seeing these staring spells and you're calling their name and they're not really paying attention to you, try to grab their arm, try to pinch their cheek a little bit, try to do these things and see if they come out of it. And then it's less of a concern. But I wouldn't have this elevated sense of anxiety. It's just something else that if you see something that worries you, please let your providers know. And oh, this is a really good question. So almost everybody with RTS has a lot of what we call epileptiform activity or abnormal activity on their EEGs, and most of those individuals don't go on to develop severe epilepsy. So you treat the child, not the EEG. So if your child has not had a seizure and you have these abnormalities on EEG, you should be aware. As certain people on this call know, the exception to that is if you see a frank actual seizure on an EEG, then that is a seizure, right? Even if you didn't know that it was before. So that, that is different than just a spike.
hand up. I don't know if there's others who've had their hand up, so.
Well, I want to thank you, Dr. Harris, because you did kind of cue me into all of that early on. But I think one of the things that I want to add to what you're saying is we got diagnosed with a very rare form of epilepsy, and it's something that we've never actually seen, like a tonic-clonic, like a Hollywood style seizure. We've never had one. We have rescue medications, but his were just like staring off spells, and he had drop seizures, which kind of came out of nowhere. But because my son has cerebral palsy as well, we thought maybe he was tripping and falling, and it took us like 3 months to finally catch one. And then he was having 100 a day. It was really, really wild. So we went from like 0 to 60 during puberty. And initially it looked like he passed out into his food a couple times and we just couldn't explain it. And still to this day, we're 3 years deep into this Lennox-Gastaut syndrome diagnosis, which even within that, they're like, you kind of live within the outskirts of that. We just really find ourselves in sort of this like rare patterning, no matter what comes, it's in a rare form. It doesn't look like any of the other people with LGS or whatnot. So I say that because when I was thinking epilepsy, I was looking for like the seizures that we're used to thinking about, not all these sort of random types, eyelids not blinking the same, but they were showing up on the EEG as actual like spiking and S waves and so on. So I wish everyone the best of luck and not to worry too much about it because you'll know when you know. But the doctors definitely said it wasn't epilepsy at first. And we had a neurology nurse who saw the first one and she's like, no, that was a seizure. And it was mind bending having to try to convince our team that they look like seizures. They're acting like seizures based on this person. And it's just tricky. I just want to say, I guess, don't give up because they might be seizures and they might be weird. There's a lot of types of seizures. Anyways, thank you.
I think that's just generally good guidance. If your gut says that we still need to be looking, keep talking till somebody listens and figures it out. So
yeah, be tenacious a little bit, even if it's discouraging.
Are there any more questions? I think Dr. Wiley's been answering them in the chat too as she goes. But I didn't want to make sure
trying
that,
a little bit.
yeah. Is there anybody else that wants to unmute, ask a question? Might get out a little early, if not. All right, well, we just want to, wait a minute. That's me left. Okay. We just wanted to, remind you of the upcoming sessions. I know Dr. Wiley mentioned them earlier. So we will have one with Dr. Jennifer Smith and Dr. Corey Keaton in regard to behavior. So a lot of your questions around anxiety and behavior and how that might manifest, they are great resources for that. They too were part of our conference presenters. So we're excited to have them. And then on Thursday, April 18th, we will have Dr. Khalil El-Shamas, and he will come and talk about those lovely GI issues that we all know and love. So we're excited to have them. As we wrap up the series, as Dr. Wiley mentioned, and we don't have a date yet, because we did the earlier part of development, we will go a little bit into the older years of development, though I feel like we were kind of all over the place today. So, but we may come back with this team to go a little deeper across the lifespan in some other spots and spaces. So we hope to have that on the calendar. And we will be doing a survey at the end of today. We will be doing a survey at the end of the series. We're planning on repeating a series in the fall. And we're going to be looking for ideas of things that you would like to cover. I know I heard Dr. Wiley say maybe we go deeper with educational things, and I'd be happy to do that with Dr. Wiley.
Yeah, I do want to. Oh, go ahead. Sorry, there's some really more like it's like the last 10 minutes and like get all your questions out.
Yes. So that was the same thing I wanted to say, Susan. There are quite a few questions chat that just came in.
Okay, go ahead.
Dr. Harris, what's your thought on the mosaicism and risk for subsequent kids?
Yeah. So this is a question that we get all the time. I wanted to make sure that everyone knows that there is something that is mosaicism, and it's different than mostly what we're talking about when we're talking about someone who tested negative having multiple kids with RTS. And that is something that's different. It's called germline mosaicism. And that means that the parent does not have any, like when they get tested in their blood, it tests negative, right? But that there may be the RTS change that got passed down to the child hiding out in just the eggs and just the sperm. Okay, so a few things about this. Number one, it is very rare, but it happens. Okay, RTS is a condition in which this has happened. There are families out there with more than one child with RTS. But we usually say if the child has RTS and the parents have tested negative, the risk is less than 1%. We can't say it's down to population risk because of this germline mosaicism, but it's less than 1%. You cannot test for germline mosaicism. There isn't anything that your providers could do to test you for it. If you have lots of, it is again rare, but if you have lots of concerns about this and you are thinking of a subsequent pregnancy, I would strongly encourage you to see prenatal genetics. So prenatal genetics is different than the genetic counselor that you see in your clinic visit, with your geneticist or whatever for RTS. This is someone who may not specialize in RTS, but that is not necessary. What they're really specialized in is talking to you about the risk of, things happening again in another pregnancy and how you can test for these things, how you can mitigate that risk, etc. And so I would definitely encourage you to speak on it, but just understand that there isn't anything that anyone can do to test for this, that it can happen, but it's pretty rare. So really, this is about your own kind of risk tolerance as a family, what you want to do and how you want to address it.
Yeah, there's also a question about when to test for autism. And I think what I guess I would say is that label can be helpful to open doors sometimes, but it's also not always easy and straightforward, right? So as I think somebody was saying, my child's got some delays, and so how do we figure out, do we also have, autistic features, or do we really fit autism? And again, I do recognize that different areas have different, kind of guidance, and some states have more access to certain behavioral supports or strategies. And so again, to me, the label may open some doors, but it's also, how is that going to help? How are we supporting a child? What are those things that, those goals that we have, what are we working on? And so even if your child doesn't have that label or diagnosis, doesn't mean you can't use the strategies that are helpful for kids with autism. But I think that's a little bit of a conversation too with your school system, or your folks who are supporting your developmental decisions. Just, how does that going to help? What does this label do? What does that mean? Does it allow me to access a more intensive program through a school district or privately that may actually help get us to the next level, and then we have more skills to expand back into a more integrated setting. I think we hit most of the questions, because I also saw Dr. Harris put some comments in too. So it's nice also to see just how far we are able to reach. Gosh, Australia, Montana, California, everywhere, it's really, and again, you guys are a great community to learn from each other. So I know Zoom is a little bit awkward to get to have those more chats and that face-to-face connection, but I'm super glad that you all are here for each other as a community.
All right. Well, if you need to get in touch with us, please feel free to reach out to either Kelly
There's
or
one
I.
more question, Celia.
Oh.
Sorry.
Okay.
Yeah, I said, Dr. Harris, I mean, the question is, almost 2-year-old who's walking, but I think the tethered cord really doesn't link to early motor skills. Would you agree with that? So
I would agree. It's more about
Did she freeze?
I think she froze. I mean,
Oh, no.
I'm not sure what she's going to say, but I would say it's kind of more the tone issues and the motor coordination that gets you walking. And then the tethering really typically wouldn't delay onset of walking as much as changes after kids are up and moving. I'm sorry we lost her. I always enjoy presenting with her because I think we kind of have a lot of similar perspectives, and she's got a lot of great experience. So it looks like she might have popped off.
So I'm so sorry.
Oh, there you are. Okay, great.
I'm so sorry. I lost internet access for a moment, but yes, no. So I think that that it has less to do with motor development. You know, sometimes you could see some exam findings that are different, but less to do. But, you know, again, I would say that, you know, and I would worry about tethered cord if you see symptoms, if you see significant, you know, bathroom changes, constipation, or, you know, urinary retention, leakage, you know, any of those things. If you see any you know, changes in their kind of development that you wouldn't expect, those are things to worry about. But, you know, if your child is progressing along as you would expect for a child with RTS, you know, I don't think you have to, you know, worry about this every day. Same thing as kind of seizures. It's just, it's something on the radar that, you know, you could be educated about it, be aware of, but it's not something you have to, you know, think about all the time.
Sorry, Dr. Harris, can I ask you something? So I developed epilepsy at the time of puberty, which we didn't know at the time, but I'm curious, do you feel like with your clinical expertise that that's something that he might grow out of? I know there's no guarantee, but like, does research suggest anything that we should be hopeful for? Because it's dire right now. I need a little glimmer of hope.
Research would suggest that kids with LGS rarely grow out of their seizures entirely. But that research would also suggest that puberty time is a time that seizures can get very bad and they can get better after that time.
Okay. And do you notice a link between RTS and LGS?
I know several kids with RTS who have LGS.
Okay.
You know, LGS is another one of those, like, you know, just a description of symptoms. LGS basically means you have a whole lot of seizure types and you have a specific pattern on your EEG, but lots of different things can cause LGS, just like lots of different things can cause autism or intellectual disability or any of these other kind of neurologic diagnoses.
That's super helpful. Thank you.